Good morning, this is Peter Petras from Sydney. I thank Professor Aristasabel for this invitation to give you a talk on the posterior Fornix syndrome, anatomical, pathophysiological and clinical aspects. Let's start with the definition of the posterior Fornix syndrome. It is co-occurring chronic pelvic pain, urge, frequency, nocturia, obstructed micturition, caused by uterosacral ligament laxity and cured or improved by USL. So posterior Fornix syndrome was first diagnosed in 1993, here is the reference, and it's associated with uterine prolapse, here, enteroceal. It's caused by lax uterosacral ligaments, you can see the prolapse coming down, and it's cured or improved by repairing the uterosacral ligaments. And here are the symptoms again: urge, frequency, nocturia, abnormal emptying, chronic pelvic pain, and in 2008 it was found that fecal incontinence and obstructive defecation were also cured or improved by uterosacral ligament repair. The pathogenesis of all organ prolapse is that the head stretches muscles, here the muscles, ligaments, nerves, because the outlet is only 12 to 13 centimeters here, and the inlet 12 to 13 centimeters, and the head at full dilatation is 10 centimeters, but the head can be 9.4 centimeters when it's flexed, and it can be 11.2 when it's unflexed, and an unflexed head, if there's a prolonged labor, can cause a lot of damage. So this diagram shows how the head, as the head descends down the birth canal here, from the inlet here to the outlet here, it can cause damage to ligaments, vagina and muscles. Now I want you to look at this diagram. The blue is the vagina, so the vagina can be injured all along the birth canal, and so can the ligaments as it comes down. Now circle number 2, we see the cardinal ligament, and right next to it, circle number 3, is the uterosacral. As it comes down further, it can damage the perineal body, and that's circle 4, and on the way out it can damage the pubourethral ligament and the external ligament. And here is the pubococcygeus muscle, so this can be injured here, here, as the head descends. Here are the anatomical pathways for normal bladder function. So bladder control is cortical and binary. That means it's either closed most of the time, so the patient can be continent, or open sometimes for micturition. Now control is actually actioned peripherally by 3 pelvic muscles: forwards, pubococcygeus; backwards, levator plate; and downwards, LMA. Now for closure, 3 opposite muscle forces, forwards, backwards, downward, contract against pubourethral ligament anteriorly and uterosacral ligament posteriorly to close the urethra here. They close the urethra here, but also, this is very important, they stretch the vagina to support the stretch receptors at the bladder, N, to control the afferent impulses to the pons, and those afferent impulses are the urge to go. So in other words, when the bladder fills, it stimulates the stretch receptors, they send impulses, and the patient feels an urge to go. For micturition, PCM, you see the circle, relaxes, and these two muscles, the back muscles, stretch the vagina backwards. It opens the posterior wall of the bladder, and the bladder contracts to micturate. Two important problems are urgency and obstructed micturition. But the key dysfunction concept is that collagen weakness in PUL here or USL here weakens the three muscles contracting against them. So if the muscles, if the ligaments are weak, the muscle force is also weak. So for urgency, if PUL or USL are loose or weak, muscle forces contracting against them weaken. So the vagina cannot be stretched. So you've got to stretch it like a trampoline to support the stretch receptors. The vagina cannot be stretched to support the stretch receptors, and sends afferent impulses to the pons, which are interpreted as urge to go. So the cause of urgency is that the muscles are weak because the ligaments are weak and they cannot stretch the vagina. Now, for obstructed micturition and abnormal emptying, let's look at these back ligaments. If they are loose, these muscles lose contractile force and cannot open the urethra. So the bladder has to drive the urine through the urethra through a narrower channel. In other words, if this can't be opened, you see the broken lines here, if these muscles can't stretch the vagina to open the urethra, then the bladder has to push the urine through a narrow urethra, and that is obstructed micturition. Now, I will discuss with you the anatomical pathway for nocturia. So here is a diagram with the patient sleeping. So when the patient's sleeping, this is how the bladder looks. And so when the patient goes to sleep, the bladder's empty here like this. As they are sleeping, the bladder fills like this. And it's distended. As the bladder fills, it is distended downwards by gravity, G. If the uterosacral ligaments here are weak, they cannot support the bladder, which continues to descend until the stretched receptors N here activate the micturition reflex O. So here's a micturition reflex O. And it overcomes the closure reflex C. Let me go over that again. Here is the empty bladder. As it fills, it descends. If these ligaments are weak, they can't stop it descending. So the stretch receptors N are activated. They give afferent impulses, and it goes through the inhibitory center. The closure reflex is overcome, and the micturition reflex takes over and wakes the patient by an urge to go. So the patient is awakened by an urge to go. Now, I will talk to you about the anatomical pathways for chronic pelvic pain occurring at multiple sites. So here's our diagram again. So now, here are the uterosacral ligaments, and here are the visceral plexuses. Now, the visceral plexuses are 2 centimeters from the insertion of uterosacral ligaments into the cervix. Now, if we switch over here, we can see that the visceral plexuses are composed of sympathetic nerves, parasympathetic nerves here, and they join together here to form the visceral plexus. Here is the uterus, and the visceral plexus is, as I said, 2 centimeters on the uterosacral ligaments before the ligaments enter the cervix. Now, I want you to think of the visceral plexus as a relay station for sympathetic and parasympathetic nerves from the end organs. So here are the end organs: the bladder, muscles, vagina, here the vagina, vulvodynia, interstitial cystitis, rectum, and the visceral plexuses are supported by the uterosacral ligaments. Now, if the uterosacral ligaments are weak, they send impulses to the brain directly from the visceral plexus, and the brain interprets these impulses as pain, but the pain coming from the end organs. In other words, the brain interprets these impulses as coming from the end organs here: bladder, muscles, vagina, rectum. And we find that when we repair the uterosacral ligaments, we can improve or cure the chronic pelvic pain, because the visceral plexuses need to be supported by the uterosacral ligaments. So this is the diagnostic algorithm. So the algorithm symptoms indicate that damaged ligament and prolapses are caused by the ligaments. So earlier I told you how the head descends down the pelvis. So these are similar diagrams. As the head descends down the pelvis, the uterus can prolapse. You have uterosacral ligament damage. You can have cystocele because of cardinal and ATOP damage. As it comes down further, you can have rectocele, number 4, rectocele. And as it comes out here, you can damage the pubourethral ligament to cause stress incontinence. So the circles 1 to 4 here correlate with prolapses 1 to 4 here, actually not quite a prolapse but stress incontinence, but cystocele, number 2, 3 uterine prolapse, 4 rectocele. And these symptoms occur with these ligaments. Okay, so these are the posterior fornix: pelvic pain, as I told you, fecal incontinence, obstructed defecation, nocturia, frequency, abnormal emptying, uterine prolapse, and rectocele. And here, cystocele has 2 symptoms: stress incontinence. Sometimes it can frequency and urgency. That's mixed incontinence. So the algorithm symptoms indicate, it tells you which ligaments are damaged here, and it would also, the symptoms also tell you what prolapses occur. So we'll talk more about the posterior fornix in the next slide. We'll discuss how to diagnose posterior fornix syndrome. You can see it's obvious because of these symptoms that the posterior fornix syndrome, that the uterosacral ligament is the most important ligament in the pelvis. Let me say that again. The uterosacral ligament is the most important ligament in the pelvis. Now, the posterior fornix has co-occurrence of these symptoms: nocturia, chronic pelvic pain, obstructive defecation, and fecal incontinence. If you see a patient that has nocturia and chronic pelvic pain, you know immediately that the problem is uterosacral ligament, because no other ligaments in the pelvis can cause nocturia or chronic pelvic pain. But there are other symptoms which can occur with USL damage: abnormal emptying, urgency, frequency. going to discuss with you a diagnostic problem. The most severe symptoms often occur with minimal uterine prolapse. So a patient can have all the symptoms of posterior Fornix syndrome, but when you examine them, you cannot see the prolapse. So this is a technique for locating minimal uterosacral ligament laxity with no apparent prolapse. This is called the reverse speculum technique. So you put the speculum in this way, and you lift up the anterior vaginal wall, lift it up. Ask the patient to strain down. The appearance of an enterocecal bulge in the posterior fornix, here, indicates laterally separated uterosacral ligaments. So in other words, if you lift that up and the patient strains and you see an enterocecal bulge, then it indicates that the uterosacral ligaments are loose. You confirm loose ligaments. So this is the speculum test. You put the speculum test gently into the vagina. It's got to be gentle. So if you get pain and urge relief by the speculum support, confirms USL, uterosacral ligament causation. And the pain, the pelvic pain, if it is relieved at multiple chronic pain sites. In other words, I may have vulvodynia, I may have pain in the lower abdomen, and this can relieve that pain. So it is a predictive test for cure or improvement of chronic pelvic pain and urge by uterosacral ligament repair. So let's go through this again. A gently inserted speculum mechanically supports the loose uterosacral ligaments here and the pelvic visceral nerve plexuses, and it prevents the impulses here going to the brain, which are interpreted as pelvic pain, and support of the stretch receptors N can also relieve the urge. So it is a predictive test for cure of urge and USL repair if it is positive. So if a patient has urgency, this is a very simple test that can be done with a full bladder. So you put two fingers gently to support the bladder base. That supports the hydrostatic pressure of the bladder, and it can relieve the urgency by blocking afferent impulses. And here we did urodynamic control. There was a patient that had obvious bladder instability, DO. Now, when I did this, it supported the bladder base and there were no unstable contractions. When this was removed, you could see the unstable contractions starting. So, bladder base support of N diminishes the afferent urge impulses to the pons. There was no urodynamic DO pattern here. Removal of digital support, remove it, causes increase in afferent urge impulses here, which activates the micturition reflex and a detrusor overactivity urodynamic pattern. But non-surgical treatment, these are the skilling, squatting exercises, and they were validated by pad tests. Now, squatting strengthens all three muscles and pubourethral and uterosacral ligaments. So these are the results. There were 20 minutes electrotherapy for 3 months, 10 to 15 squat 3 times daily for 3 months. Importantly, the patient was encouraged to change her normal activities to develop a squatting culture. In other words, squatting to pick something up, squatting to play with the children, squatting for normal household tasks. Now, importantly, these results were mainly premenopausal women, okay? Mainly premenopausal women. So there were 78 women, and these are the numbers, and these are the conditions that were improved. 50% improvement. Now, out of the 69, 57 women reported 82% improvement. In urge incontinence, 33 women, there were 44 with urge, 33 reported 68%. Sorry, let me go over that again. There were 69 women. Of these, 57 and 82% of these reported 50% improvement. Urge incontinence, there were 44, and 68% reported 50% improvement. Frequency, 83% reported 50% improvement. Nocturia, 32, 29 of these, in other words, 90% reported 50% improvement. Chronic pelvic pain, there were 17, 13, 76% reported 50% improvement. And most interestingly, the residual urine, there were 23 women with high residual urines, average 202 ml, and it was reduced from 202 to 71 ml. Okay. This is a very important study by Shkarupa et al. From the University of St. Petersburg, Russia. They did a native ligament, cardinal and uterosacral ligament repair with Vicryl in pre- and postmenopausal women. It demonstrates why collagen-creating techniques, either tapes or number 2 polyester sutures, are recommended for prolapse or incontinence surgery. So the key concept here is that ligament collagen breaks down at the menopause. So in premenopausal women, normal collagen, there were good results here at 18 months. But in postmenopausal women, which has poor collagen, very poor results at 18 months. This is for symptoms, OAB symptoms, and prolapse. So, I'll just go through these quickly. Frequency, urgency, nocturia in premenopausal women. These were the cure rates at 18 months. 59.2, urgency 67, nocturia 87, pelvic organ prolapse 79.6. This is native tissue repair at 18 months. Now look at the postmenopausal group. Frequency 15.4 as against 15, 17.9, 63 premenopausal, 20 nocturia instead of 87 for premenopausal. And for prolapse, 15% against 79.6. Shkarupa recommended collagen-creating techniques must be used. In fact, also with the premenopausal. Now, this is a large study, 611 women, multi-center. It showed that prolapse and symptom cure at 12 months after uterosacral ligament repair with collagen-created TFS mini sling. Any sling can do it. So, chronic pelvic pain at 12 months, 77% cure. Nocturia, 68%. Urge incontinence, 85. Frequency, 83. Fecal incontinence, 65. Apical prolapse, 90. Now look at this again. When you compare this with Shkarupa, look at the cure rate for postmenopausal symptoms, very low. Prolapse, very low. I'll go over this one more time because it's very important. Symptoms can give you very good results at 12 months compared, and the average age of these women was 70 years of age when compared to native tissue repair. So the final message is, collagen is very important. When you operate on these women, you must have a collagen creating system. Gracias, thank you very much.